Hello, everybody. Good morning, the Americas. Good afternoon, Europe, and good evening or good night for our colleagues from Asia and Pacific regions. It's like a premiere to have this comparative therapy symposium with colleagues coming from dermatology, but addressing different patients, dogs. And this meeting has been arranged in very close collaboration with our colleague, especially Pascal Prelot and Thierry Olivry. I just want to say a few words of introduction. So clearly, I think it's quite timely to have this meeting because the therapeutic experience is different. And for example, when we speak about targeted therapies, and even small molecules or semi-targeted therapies, our colleagues working with dogs have the experience of targeting the IL-31 pathway for now several years, and we have very limited experience. And on the contrary, we have now sufficient experience targeting the Th2 pathway. So I think it's interesting to exchange our experience over this symposium, 2.5 hours. We have 1.5 hour of talks and 1 hour of discussion. I just want to mention 2 things before starting. First, it's the memory of my colleague Didier Noël Carlotti, a pioneer in the field of veterinary dermatology, who died a few years ago, and he had a career parallel to mine in Bordeaux, and we shared experience, and we shared also trainees, mostly trainees from his clinic came to see my patients, and sometimes the patients were a bit surprised to be examined by a vet doctor, but the exchange concerning comparative dermatology were very exciting. And Didier left a large legacy to the field. He is well remembered by all his colleagues, and just I want to mention his name on this occasion. And second, just to introduce this from a historical perspective, because this is a picture taken before the name atopic dermatitis was proposed in the human field by the Weiss and Sulzberger. It was published in 1926, and you see the topography, which was the most probably diagnostic feature at this period. When you read the text from Charles Lebois in this book, which was in our university clinic in dermatology, you see that many aspects concerning each are very difficult to distinguish because of course, infestation, parasitic infestation in particular in animals. But the topography was really the main diagnostic feature noted at this time. And he was a real pioneer in the field. And I want just to leave the rest of the introduction to Thierry Olivry, and maybe all the panelists can say a few words to present themselves. Thank you.
Good morning or good afternoon, and I'm Thierry Olivry from North Carolina State University, and I would like to thank Professor Tayeb for having given us the opportunity to participate. I would like to take this opportunity to welcome everybody, veterinarians, dermatologists, and physicians, pharmacists, and scientists. For those of you who, as I am, are interested in atopic dermatitis, you've probably already read the several articles that have been published in the JID comparing the clinical signs and the immunopathology of the human and canine diseases, showing how intricate and how similar these diseases are. What we have not had so far have been either papers describing the comparison of the therapeutic schemes and drugs that we have, or we have not had even lectures before comparing human and canine dermatology, at least recently. In the last decade, there has been a lot of advances in the human field in the new treatments for atopic dermatitis, from the dupilumab to the JAK inhibitors or the crisaborole. And similarly, in veterinary dermatology, since the early 2000s, we have had 3 drugs now that have been approved in many countries to treat atopic dermatitis in the dog, starting with the cyclosporine, the Atopica from Novartis, and then the JAK inhibitor oclacitinib, Apoquel in 2014, and then recently the anti-interleukin 31 monoclonal antibodies. So today we have the opportunity to share our experience with your, at least on the human side, your drugs, and then we will share how we use our drugs. And I hope that we can continue this cross-fertilization over the next few years. So anyway, welcome to everybody. Pascal, do you want to introduce yourself?
Yes, I'm Pascal Prelot. I'm a vet dermatologist and I'm working on atopic dermatitis for almost 35 years. And I remember when I began on this subject at the vet school with Thierry a long time ago then. And I must say that for years we learned a lot from human atopic dermatitis, and then we did improve our knowledge through comparison with the human disease. And it's very good to do this section about the treatment today, because there is a lot of big differences because a dog is not human, and a lot of common things because we are dealing with the same disease. And that will be the beginning of my topic today.
Maybe we can follow with Dr. Tamamoto Michizuki.
Hi, my name is Chie Tamamoto Mochizuki, and I'm a veterinary dermatologist. And also, I'm currently doing the postdoc at the North Carolina State University, and I've been studying about the canine atopic dermatitis in dogs since I was a PhD student. Thank you.
Then Professor Martin Steinhoff.
Hello, everyone. I'm Martin Steinhoff. I'm the Chairman, Department of Dermatology, Weill Cornell in Qatar, and also Director of a Translational Research Institute. So translation also means, so I'm interested in everything from molecular mechanisms to clinical trials, and we have described some of the mechanisms which are also we discussed today, whether it's the interleukin 31 pathway or also protease activated receptors. So everything from that, going from the molecular mechanism into the clinic, is of my interest.
Professor Kenji Kabashima.
Hi, this is Kenji Kabashima from Kyoto University. I'm a dermatologist, but I'm also interested in mouse pathogenesis, and also we have a dog here. So I'm also interested in canine atopic dermatitis. So I'm very excited to join this meeting. Thanks.
Roberto Takaoka.
Hi, everybody. I'm Roberto Takaoka from Sao Paulo, Brazil, currently the Vice President of ISAD. Very interested in the subject. I remember when I was working with Dr. Hannafin in Portland, it was the first time I heard about the Basenji Greyhound model for atopic dermatitis. So this will be very interesting to hear about the subject. Thank you very much.
Professor Andreas Wollenberg.
Hello, I'm Andreas Wollenberg. I'm the secretary of the ISAT, and I have been interested in the field of atopic dermatitis since almost 30 years, coming into contact with canine atopic dermatitis through my good friend, Professor Müller from Munich, who is also working with canine atopic dermatitis.
Okay, Professor Claude Favreau.
Good afternoon, everybody. I'm Claude Favreau from the Vet Suisse faculty in Zurich. I am a vet dermatologist. I have also one dog who is very interesting with the topic today. And yes, I I had the opportunity to develop a model of canine atopic dermatitis in Zurich, and we have tested several approaches to treat the disease, and maybe it could be something that we can discuss afterwards.
Professor Liza Beck, she's now on the screen.
Hello, everyone. My name is Lisa Beck. I'm a dermatologist who for 30 years has been focused on atopic dermatitis. I'm particularly interested in the role of type 2 immunity and its effects on epithelium and staph abundance. And I have an interest in canine AD for quite some time because I've had golden retrievers, several of which have been on Apoquil. So really interested in the dialogue we have today.
And Amy Peller from Northwestern University in Chicago. So I think I leave the microphone to Thierry to introduce the first talk. Please, Thierry.
Again, it's my pleasure to invite my former classmate, Pascal Prelot, to begin the discussion by a short presentation of his viewpoints on how the two diseases compare on a treatment point of view. Pascal, the floor is yours.
Yeah, thank you. I have to share my screen, I think. First of all, I would like to thank everybody that we did it already, and I would like to remind you that the One Health concept is quite important, and we saw that with the COVID, and we know now that it's really important to share our knowledge between human and animal medicine in both ways. And if you look at the dog, it's difficult to imagine that you can have any things common with human, because it's a hairy animal living on 4 legs, which is full of parasites, with a behavior which is quite different from human, with a quite different type of food, which is very important, in fact, with the genetics which are really specific, a life duration which is quite shorter than human, and a way of doing medical work and technique which is quite different. But there is a link between human and canine atopic dermatitis, which began in 1981 when a couple of owners, which were allergic to ragweed, realized that the dog was itchy, sneezing at the same time at them, and then this dog was described as the first atopic dog with a ragweed allergy. And since this first case, for years, atopic dermatitis was linked in veterinary medicine to allergy to aeroallergens. Hopefully, thanks to people who worked in comparative medicine, we just realized that this was not really true, and that canine atopic dermatitis is quite close to human atopic dermatitis. And it is almost the same disease, with clinical signs which are quite almost the same, with location, pruritus, with diagnostic criteria which are really close if you compare dogs and human. And there is also skin barrier defect. With this skin barrier defect, itch, skin inflammation, vicious circle that you can observe in both species. There is almost the same inflammasome, and Terry will be back on that subject later. And of course, we then shared a lot of different research and way to treat for almost 1 century now. And for example, now there is more and more work on microbiota in atopic dogs. And there is also a lot of common therapeutic approach. And the main example is cyclosporine that we used after the first results published in human beings. But there is a lot of difference between the dog and human. And the first one for atopic dermatitis is that in the dog, there is no atopic march. It is mainly a disease of the adults. So what we observe in the dog is adult dogs or young adult dogs with the same disease all the lifelong, And of course, their life is quite short. It's 15 years, so we don't know what can happen later. Another difference is the pruritus mediators. And what is very spectacular, it is that histamine, for example, injected in the dog do not provoke pruritus, but it can provoke urticaria, like you can see in this dog. Another big difference, and since we are dealing with the treatment today, is the fact that the dogs have hair and they have match hair. And this is one of the main problems we have when we do dermatology, that we do not see the skin, in fact. And because of this hair, we prefer quite often systemic treatment in the dog, except in very located form of atopic dermatitis. And we also developed some specific topical products like spot-on or foam, because cream ointments are really not useful in hairy areas. Compliance is also something very, very important in practice. And if you deal with atopic dogs, you have to make a lot of topical treatment, like shampoo, like putting spray or ointments, and also to give pills or injection. So it's a lot of work, and it is something very, very important to think about when we are dealing with the treatment, with the long-term treatment of atopic dogs. Also in the dogs, in the atopic dogs, there is a lot of comorbidities, especially in some specific breeds, which leads to the need for systemic treatment. So it is another point for the use of systemic treatment in atopic dogs. Another big difference between human and dogs is that in veterinary medicine, we are used for years to use therapeutic food, and because it's very easy to use only one food in a dog, which is quite almost impossible, of course, in kids. And of course, we use that to do elimination diet to diagnose food allergy, but it can also used to treat or help the treatment of atopic dogs, like you see in these beautiful papers published recently by Claude's team, where you see that there is a decrease of drug consumption with the feeding of a food which is rich in some essential fatty acids and antioxidant additives. Another way also of the way to use food could be to prevent the development of atopic dermatitis, or at least to minimize sensitization to house mites, like it was demonstrated in this very impressive publication where puppies were fed a food again enriched in essential fatty acids and some antioxidant products. Another point, and we never speak about it because it's very vulgar, it is the fleas. And flea infestation in the dog and the cat, of course, is quite common. And the flea control is essential because flea bites can provoke a flare of atopic dermatitis in atopic dogs. And it is so spectacular that in this paper, which was a paper study on the efficacy of two anti-flea products, Floranor and Afoxolaner, which included dogs with a chronic pruritus and mainly dogs with atopic dermatitis, you can see that with only the treatment of the fleas, you can control almost, if not all, the pruritic disease. So fleas is another big difference between human and dogs. Another difference is the medical culture. In veterinary medicine, historically, dermatology referral practice was based on RG testing. Thanks to these first cases, which were described as an allergy to aerogens, for years and decades, and maybe still, there is a lot of referral not to take care of atopic dermatitis, but to do RG testing. And this is a huge business. And in fact, for a long time, GPs were doing symptomatic treatment of atopic dermatitis, and the specialists were making allergen testing and allergen-specific immunotherapy. Hopefully, this is not the case anymore in most countries. The allergy dogma is almost dead, but this is still a strong dogma in veterinary dermatology. And also in vet medicine, when you go to the vet, the clients are used to see the vet making an injection. So the vets make an injection, and it works. And of course, they did for years steroids, long-acting steroid injection to atopic dogs, and the owners are waiting for the injection all the time. And this is why we're used really for a long time to systemic treatment of atopic dermatitis too. And I will end with the pharmacology and toxicology, which is quite different. And here, an example of hypertrichosis due to cyclosporine use in the dog, like in human. But in the dog, you do not have a renal insufficiency, you do not have hypertension, etc. So it's not the same toxicology, and we must take care of that when we compare both diseases. And the price of the treatment is also something which is quite different and quite difficult to deal with when you are treating atopic dogs, which needs systemic treatment. And here is an example of the monthly cost with different systemic treatment of 10 kilograms in blue and 40 kilograms in orange. And you can see that for cyclosporine, it is not cheap, but not so expensive if you have a small dogs, but it's very expensive in France if you have big dogs. Oclacitinib is always in the range. And for lokivetmab, it is expensive in both cases, but you can see that lokivetmab injection is not so expensive compared to human medicine because it's around 80 to 150 euros per month. Here is another point, is that this cost differs between countries. And this is slides from Thierry, who did compare the price of different treatment. And you can see that for 20 kilograms in the States, the Apoquel is quite less expensive than the others. But if you go to Poland, it is almost as expensive as cyclosporine. And if you go to Spain, you see that Apoquel is still not very expensive, but cyclosporine is very expensive. And in Argentina, it's the opposite. You can see that Apoquel and cyclosporine are much more expensive than cyclosporine. So we'll end here to go through the true subject of the day. And my conclusion is that in the dog, since there is hair, the compliance is something very important, and the quality of life of the owner and the dog is also something very tremendous, and that we have to take care of the cost of the treatment. We prefer in severe cases or moderate cases often to use systemic treatment with a very fast effect, and we like to develop proactive treatment because it's better to prevent flare than to treat flare in these dogs, especially in terms of quality of life and cost. So what we can bring you, maybe, it is our use of systemic treatment in routine, and in veterinary medicine, systemic treatment like lokivetmab, like oclacitinib are used by general practitioners. You don't need to go to the hospital to go to see a specialist for that. And also we use quite much now proactive systemic treatment, and Thierry and Kie will speak about it later. Thank you.
Thanks very much, Pascal. I liked your last slide with biting men. And well, and I will introduce now the second talk by Liza Beck. And she is a very good specialist of the new treatment, especially in adults. And for us, the revolution was clearly dupilumab, which was used first in adults. I think even if the disease, for us, the prevalence is very high in children, so the revolution came in adults. And I thank very much, Liza, for covering this part.
Thank you very much, Alain. And it's a real pleasure to be in this group. I'm so glad we're doing this because it really, the cross-fertilization across canine and human is greater than it isn't, right? So I changed this title to moderate to severe because that is the group that we treat with this new Th2 blocking drug, dupilumab. And here are my disclosures. I have been an investigator for Regeneron's dupilumab trials for atopic derm for all ages. And I thought because we have our vet colleagues here, just giving them the current prevalence data for this disease, which we think in 70 to 80% of the patients does begin in childhood, so different than canine. But I think once we had dupilumab in development, a lot better data came out about the prevalence in adults. And it turned out to be actually much more prevalent than we originally thought. So those are the estimates. One of the features of this disease that I know is also in common with canine is a susceptibility to skin infections. And although the viral infections are probably less common, they're quite distinctive and can be, in some cases, quite severe. The more common situation is to have a staph infection that's either just colonization or true features of infection. And many of our patients do have concomitant other atopic conditions. This is the most common comorbidity in our patients, much more commonly seen in our younger patients than in our adult and certainly than in our elderly. And we used to think of this as a triad, but now we really call it a pentad because these are the most common allergic comorbidities seen in our patients, although it's rare to see all of them in one patient. So when we think about the disease in probably both canine and humans, we think about these various features. And it's shown here that they're highly interactive. We've got a lot of in vitro and mouse data and human correlation data that says that these various features of the disease don't act independently. And it's still unclear which one of them really drives the disease, although a quarter of a century of data says that the inflammation in the dermis is a key driver, and that inflammation does seem to be best characterized as type 2 immunity. We had previously looked at the association of type 2 biomarkers and a variety of the features that I showed you on the previous slide, the circle with the various features. And in this case, we're just showing you total IgE, and that it correlates strongly with those patients that are colonized by culture techniques with staph. We can show you a similar slide that shows that it also correlates with barrier dysfunction and that it correlates with disease severity. So greater evidence of systemic type 2 immunity associates with all three of those, but does not associate, interestingly, with itch. So that brings us to the drug that's a fully humanized monoclonal antibody that directs against the IL-4 receptor alpha subunit that's common to the type 1 and type 2 receptors. IL-4 binds to both of these, whereas IL-13 only binds to the type 2 receptor. And as you know, this biologic is approved for a number of allergic conditions shown here. Excuse me, and you can see here the approval dates for these, for dupilumab for atopic dermatitis. And you can see that now worldwide, we have this available for adults and for children. So this is the duplicate phase 3 trials. In human disease, you have to do 2 identical phase 3 trials to submit them for regulatory approval. And so they're called SOLO 1 and SOLO 2. They looked at 2 different doses of dupilumab, Q2 week versus Q1 week. And I've graded the Q2 week. That's the approved dosing worldwide. And what we're looking at is the % drop in something called Eczema Area and Severity Index, which is virtually looking at the signs of the disease with no contribution of symptoms. You see a dramatic drop in this score, suggesting a significant improvement. And this seems to almost be near max by 12 weeks into treatment. A very important feature of this disease in both dogs and humans is the itch. And so we assess this by a numerical rating scale, or NRS. And again, same study design, same dosing. You can see within 2 weeks, there's statistical improvement in the itch seen in these patients, and it seems to reach the max again within 16 weeks of treatment. So one of the things that was surprising by that itch improvement was when this data came out clinically, we did not have a mechanism to explain why IL-4 receptor blockade would improve itch. And so Brian Kim, as you all know, then did some elegant in vitro and mouse studies to demonstrate that IL-4 receptor alpha is present on sensory nerve endings. And although it doesn't trigger much of an itch response, but it does sensitize those sensory nerve endings to other peritogens. So it seems to be an amplifier of other peritogens' itch, and that probably explains the improvement seen in humans with dupilumab. So Amy Paller presented this at the EADV this year, looking at how it improved a measure of sleep loss. And so one of our scoring systems called SCORAD has a sub-score that looks specifically at the sleep loss. And this is looking particularly at our young group. This is 6 to 11 years of age, so these are our children. And you can see in the pivotal randomized phase, which is in the darker blue, you see a significant drop in that sleep assessment that really had only a modest drop in the grade placebo. Then there was a lapse in therapy, and then they got rolled into, after that hatch line, into everyone getting therapy or open label extension. And again, you see the placebo group, again, improving similarly to the original dupilumab treated group. So sleep improvement is a feature of this disease, and this is true for all age groups. If we look at long-term management, this is 1 year, and this looked at the Chronos study, and Chronos included the use of topical corticosteroid in both arms, dupilumab and placebo, that at the pivotal endpoint of 16 weeks, you saw a little over 40% of patients had a 90% improvement in the EASI score, again, a score of signs of the disease. That improvement was sustained in the open label extension, or in the extension phase of this, with slight improvement in the EASI 90 achieved 1 year out over what you saw at 16 weeks. And then to just show you that this has now been extended to 3 years, and just for simplicity, I show you eczema area and severity changes over a 3-year period in adults treated with dupilumab. Then you look at 2 measures of itch, and then you finish with 2 measures that are quality of life measures. And you can see based on the color bars that you continue to see a modest improvement as you continue this treatment over a 3-year period, although most of the improvement is typically seen in the first 16 weeks. To try to understand exactly why dupilumab is improving the disease, this was the EXPLORE trial, which looked at an unusual dosing scheme. It had no loading dose and injected dupilumab at 200 milligrams, even though these were adults. So this is a lower dose than what's FDA approved or EMA approved. But if you look at the left, what they're measuring is the lesional PCR quantity of Staph aureus. And the placebo group, we see no real change, although what's always notable is how varied the amount of staph is on our patients. If we move to the right graph, where this is the dupilumab randomized group, you can see within the first 4 weeks, we already see a statistical drop in PCR quantity of Staph aureus on the lesion, which becomes slightly or numerically greater at 8, 12, and 16 weeks. And then when you stop treatment, you can see that it starts to return close to baseline. So this does suggest that dupilumab may have an effect on this staph abundance, which is really the bacterial problem on the skin. So now, looking at whether this relates to staph infections, this is a recent poster that Amy Paller presented at the EADV and looked at the 2 pediatric trials, both 6 years of age all the way to 18 years of age, and looked at the report of non-herpetic skin infections. On the left is the reports, and then on the right is adjudicating these reports. And what you see above each one of these histograms is the relative risk. So you can, regardless of which way you report it, there's a significant reduction in the relative risk of non-herpetic skin infections as a consequence of all the dosings of dupilumab in these trials. So Emma Gutman has also looked at a number of trials as well, particularly focusing on epithelial changes, and she has a lot of transcriptome changes that have been observed in dupilumab-treated patients, but this is showing keratin-16 immunoreactivity, and then the top is the placebo group, and the bottom is the dupilumab-treated group, and you can see a significant drop in the keratin-16 staining, which is a marker of keratinocyte activation and proliferation. So there's definite evidence that dupilumab normalizes some of the epithelial features, and we're still wondering whether it would improve barrier function. So Emma Gutman's group and several others have looked at transcriptome features in human skin lesions of atopic dermatitis and noted that they aren't completely similar across all ages of AD or across different racial groups. And so here is her cartoon where it's clear that most patients do still have a prominent feature of Th2 cytokines, but some groups also have quite a bit of Th22 or IL-22 expression, and some groups have more IL-17 expression. I think the importance, though, of type 2 immunity is really shown by this review article that looked at the improvement in SCORAD over a 16-week period in various systemic treatments in human subjects. And the dashed line is placebo, but you can see dupilumab is almost as good as high-dose cyclosporin. And you'll notice that fezukinumab, which targets IL-22, is not different than placebo, and the same is true for a small study with ustekinumab, which is a biologic that would block Th1 and Th17 pathways. So based on this, one would argue that even though there are some age and racial differences in inflammation, it doesn't appear yet to be demonstrated by these trials. And Andrew Alexis actually took a look at the adult trials that have been published to date with dupilumab and specifically looked at whether there were any differences based on whether individuals were Caucasian or white, Asian or African American or Black. And the numbers were pretty significant worldwide across these adult trials, and found no real differences in efficacy or safety, although there was a general trend in Black patients that a Q weekly dose had a little advantage for efficacy over a Q2 week dose, which probably reflected the higher BMI in that racial group. So we mentioned that our humans commonly occur with comorbidities that we would characterize as atopic. And so in this publication, it's looking at the adult trials again and noting that almost 30 to 32% of our adults with atopic derm, moderate to severe atopic derm, who entered these trials had features of asthma. And of those, almost 40 to 45% had poorly controlled asthma. And then if you use the SNOT-22 questionnaire to assess sinonasal symptoms, you could see that about 44 to 50% came in with allergic rhinitis type symptoms. And then in the lower yellowed bar, you can see the number that had both features, asthma features as well as sinonasal features. So the question we asked in this study was, did the AD patients entering this study who came in with history and symptomatology to support that they had either poorly controlled asthma or mildly controlled asthma, did we see improvement in their asthma? And so you could see the two different dosing schedules, the blue and the purple. Q2 week is blue, Q weekly is the purple. And you could see whether you're taking all asthma patients on the far left, or if you move to the right of the first graph, those are asthma patients that are poorly controlled. You could see that there is improvement in both of those in their ACQ-5, which is an asthma questionnaire, suggesting that 80 patients with asthma see their asthma get better in these trials as well as their eczema. And if we move to the right, this is the sinonasal symptoms, and a change of 8.9 is indicative of a significant improvement in their sinonasal symptoms. And you see again that we see improvement with both dosing schedules. Although there's no statistical difference between the Q week and the Q2 week, you can appreciate there's a numerical difference suggesting the Q week is superior to manage that. So side effects have been really pretty mild with this therapy. We don't consider it an immunosuppressive, so there's no screening for underlying infection or TB. There's no laboratory requirements, despite the fact that there have been reports of transient eosinophilia in the pivotal trials, which has generally been of little consequence. The biggest problem we probably deal with in the clinic is a range of ocular features that patients develop. We think 90% of the cases that do develop are mild to moderate, and in the real world, the frequency of this is anywhere from 18% to 60%. So it depends on how low your bar is for reporting ocular features. It typically begins with dryness, then can progress to conjunctivitis or blepharitis, as you see here. It's more common in our atopic derm patients with more severe disease, more common in our adults, and more common if they are highly type 2 polarized or have a history of allergic conjunctivitis. Most of the patients stay on the medication, and we were really fascinated by the fact that this is almost never seen in our asthmatics, chronic rhinosinusitis with nasal polyposis patients, or in the EoE patients. A number of other assorted post-marketing side effects have been noted with dupilumab. I'd probably say in my practice, the most common is a psoriasiform sort of dermatitis, occasionally with a little bit of arthritis. We're suspecting this is because you block Th2, you block the seesaw reaction with Th17. And there's also some reports of new onset CTCL or unmasking cutaneous T-cell lymphoma. So let me conclude by saying that AD is incredibly common in humans, more common in children than adults. There are different phenotypic and endotypic variants, although the majority of our patients do respond to dupilumab, regardless of their race or ethnicity or immune profile. We see significant improvements in signs and symptoms that are quite quick, but probably not maxed till about 16 weeks. They're sustained over 3 years. There's a drop in staph colonization and a reduction in bacterial non-herpetic skin infections. I didn't have time to show you a vast amount of data on improvement in quality of life, as well as anxiety and depression that about 40 to 50% of our patients suffer with, and a number of improvements in atopic comorbidity. So it's nice that we have a therapy that in some of our patients might actually treat 3 diseases rather than just their eczema. The safety profile is still looking really quite good. And so let me end there.
Thank you very much for this nice review. I'll leave next presentation to Thierry.
So my presentation, joint with my friend and colleague Chie Tamamoto Mochizuki, is about the anti-interleukin 31 monoclonal antibody lokivetmab for atopic dogs. So why is interleukin 31 a good target in dogs with atopic dermatitis? I must admit that at the time when I presumed the lokivetmab was developed, not much was known about interleukin 31, except that it caused itch in a variety of species, mice, dogs, human, monkeys. But there was very little demonstration that it was critically important as a pruritogen for atopic dermatitis. In fact, in 2016, we reported a study performed a couple of years before, where we used our dog model of atopic dermatitis, which are atopic dogs that we sensitize to house dust mites, and we can provoke, as you can see here, very mild lesions, which microscopically are more inflamed. But when we looked using a microarray technology at the transcription of most of the known pruritogens at the time, we were really surprised to see that interleukin 31 was the gene that was highest expressed of any of the genes that we looked at. And this was really a surprise because it had not been shown at the time. And very recently, Chie, as part of her PhD, demonstrated that not only are the genes upregulated, but that the protein is expressed mostly by helper T cells, and that this expression is somewhat transient. It occurs within the first day or two after an acute allergen challenge, but tends to decrease later on. So it seems that the interleukin-31 is relevant for atopic patients, but it probably has a transient expression rapidly after an allergen challenge. You all know about interleukin-31. It's a cytokine that's expressed by a variety of cell types, in particular Th2 cells, but also all of the usual culprits in atopic skin inflammation. The receptor is expressed also by a variety of septides of some cells, and some of the structural cells like keratinocyte and sensory nerves express the receptor. We also know that in the dog, as in other species, the interleukin-31 can directly stimulate sensory nerves to create itch. And that interleukin-31 is a pruritogen is now known in several of the species of interest. And what is remarkable is that interleukin-31 can induce both an early itch within minutes of its injection into the skin or intravenous. But in human, for example, and mouse, and dogs, and we don't know yet for cats, there is also a secondary itch that occurs within a couple of hours or even later than that, suggesting that interleukin-31 can stimulate some cells to produce secondary pruritogens. So it is both an immediate and a delayed pruritogen. How can we target interleukin-31? There are two drugs that are specifically available to target these pathways. We have the lokivetamab that was developed years ago and was approved in 2017 under the trade name of Cytopoint by Zoetis, which is the former Pfizer Animal Health. And then you have on the human field, the nemolizumab, which targets the alpha chain of the interleukin-31 receptor. And we will hear in the next presentation about the nemolizumab. We propose that there are two possible use of lokivetamab and perhaps also of the nemolizumab. We separate traditionally, and this is something that we in veterinary dermatology were inspired from the publications on human atopic dermatitis, but we distinguish reactive therapy, which is in a patient which has active lesions to induce remission. And the reactive therapy typically starts until we go below the threshold of lesion and we continue a little bit longer to stabilize the remission. And then we have the proactive therapy, which is the maintenance of therapy to prevent the relapses. And typically we use then intermittent therapy, which initially was developed with topical glucocorticoid in humans, then in the dog. And we propose that we can use the lokivetamab both reactively, but also proactively. And I will cover the reactive part. Chie will move to the proactive therapy. I will show you here the best trial of lokivetamab monotherapy for treatment of dogs with atopic dermatitis. They are usually moderate to severe disease. This was a randomized controlled trial that led to the approval of the Cytopoint by the EMA. The cyclosporine was given at a traditional dose of 5 milligrams per kilogram once daily. This is a dose that is very safe in dogs and that is used for the long term. And the lokivetamab in Europe was given at 1 milligram per kilogram every 4 weeks. In the US, it is approved at 2 milligrams per kilogram every 6 to 8 weeks. The cyclosporine, as you can see here, is in red. The lokivetamab is in blue. Let's look first at the effect on itch, and we use, as you do in humans, the visual analog scale to show the evolution of itch. All patients started with what would be characterized in average as a severe itch. You can see that during the first week of therapy, the lokivetamab is far superior to the cyclosporine, inducing itch, to reducing itch, and then you can see that it reduces further. After 84 days, the 81 dogs that were responders by a reduction of itch after lokivetmab were continued, and you can see that they were stabilized to a level that in average corresponds to a normal itch for an atopic dog. But as you can see here, the standard deviation is quite high. And if we look at the mean plus 2 standard deviation, it is clear that some dogs were at 0 for their residual itch, but some dogs were still in the range of moderate to severe itch. And that is something that is quite, that has been observed many times with this antibody. There are patients that have a pruritus that responds dramatically and completely, indicating that interleukin-31 is a major or the only pruritogen in these dogs. But there are others in which the drug doesn't work as well or doesn't work at all, indicating that interleukin-31 is either partially responsible for the itch or not at all in this patient. If we look at the percentage of dogs that have an itch, that residual itch in the range of that of normal dogs, you can see that throughout the trial in the controlled phase, it outperformed the cyclosporine, but this is not surprising. Cyclosporine is not uniquely targeting a pruritogenic cytokine. And you can see that in the long term, 70% of the dog have a normal level of itch, which is really quite exceptional by just blocking a single cytokine. This highlights how interleukin-31 in many or most atopic dogs is a critical pruritogen. If we look at the reduction of the skin lesion score in dogs, we have the Canine Atopic Dermatitis Extent of Severity Index, which in principle evolved like your EASI and the SCORAD. And you can see here that on skin lesions reduction, cyclosporine and lokivetmab performed equally. And that in the long term, in average, the on lokivetmab had an average CADESI that was in the range of mild atopic dermatitis. Obviously, with the standard deviation, some were clearly normal, but some were not. And that highlights in my mind that the interleukin-31 is probably much more important for itch than it is for skin lesions. And this has been shown actually by the experiments using anti-interleukin-31 in mice or nemolizumab in humans, where the effect on itch seems superior to that of skin lesions. But there are reasons to explain this. Here is the same chart showing that the differential, this is the percentage of dogs that have a CADESI score in the range of normal dogs. You can see that there are fewer dogs that reach a normal level at 84 days with either drug, and that about only half of the dogs have a normal skin lesion score. And this is to be compared with the 70% of dogs that had a normal itch level. So I showed you this slide earlier to show that interleukin-31 is the most important cytokine that we identified transcribed early after an allergen challenge. This led us to wonder if we could use the lokivetmab proactively, using it in patients whose signs were in remission to prevent flares. And this is what Chie will now share with you.
Okay, thank you. So the first, we tested the lokivetmab proactive therapy in our multi-beagle atopic dog model. So we first, these dogs were first proactively pre-treated with IL-31, anti-IL-31 lokivetmab injection 7 days before we induced the flare of atopic dermatitis by applying the houseasmide topically. So results show that, So the results show that the 90% of the pruritus was proactively inhibited by this lokivetmab treatment. And on the other hand, interestingly, the skin lesions was not prevented by this lokivetmab proactive therapy. But however, at least this study further confirmed that the IL-31 is one of the relevant pathogens involved in acute Canine atopic dermatitis itch. So we also tested this lokibetamab proactive therapy in clinical cases. So this was an open study enrolling 21 client-owned dogs with atopic dermatitis, and their clinical signs of atopic dermatitis was no to minimum when they received the first lokibetamab injection, meaning that the lokibetamab was used as proactive maintenance therapy for these dogs. So even though these dogs received monthly regular lokibetamab injections, the flare of atopic dermatitis needing additional anti-allergic medication was seen in half of the dogs within 2 months. And also a long-term control in atopic dermatitis was only seen 1/3 of the dogs. So why are there so many so many flares of atopic dermatitis after this lokibetamab proactive therapy? So as I showed earlier, the IL-31 was one of the most relevant pathogens in atopic dermatitis in dogs, and this itch was proactively prevented by lokibetamab injection. And however, the skin of atopic skin inflammation was not prevented by these lokibetamab proactive therapies. So we hypothesized that it was because this skin inflammation was contributing to these atopic relapses. So then our next question was, so in that case, so which cytokines are still upregulated after this lokibetamab proactive therapy, which are likely contributing to this acute phase of atopic skin inflammation in dogs? So in a crossover study enrolling our, again, atopic beagle models, and we performed the comprehensive analysis of cytokine profiling of skin from the atopic skin lesions with or without anti-IL-31 lokibetamab proactive therapy. So overall, we did not see any major difference in the gene expression of cytokine in between with or without lokibetamab proactive therapy. And for example, pro-inflammatory cytokines such as IL-6 or IL-33 were still significantly upregulated compared to the baseline, even after the lokibetamab proactive therapy. And similarly, Th2 cytokines such as IL-13, CCL17, or CCL22 were still significantly upregulated compared to the baseline, even after the lokibetamab proactive therapy. And lastly, IL-9 was another cytokine that we found to be still significantly upregulated compared to the baseline, even after the lokibetamab proactive therapy. So taking all together, so these cytokines, meaning IL-6, IL-33, IL-13, CCL17, CCL22, and also IL-9 could be the main contributors for the atopic skin inflammation in acute phase of Canine atopic dermatitis. And these could be very good valuable targets to prevent the atopic relapses, especially together with this IL-31 inhibiting lokibetamab therapy. So in conclusion, so the lokibetamab showed its effect in reactive therapy, in Canine atopic dermatitis. And also it showed its potential effect in proactive therapy. But also we might need to consider targeting additional cytokines, which are likely responsible for the acute flare of atopic skin inflammation in these dogs to have better control of our patient for a long term. So with that, we like to thank all of your attention and thank you for taking your time.
Thank you very much. I think IL-31 has a Japanese flavor. So it's a switch to Kenji, because Kenji is going to discuss the human molecule which targets the receptor, and this molecule was developed also by Chiba in Japan, and now is reaching the phase 3 studies, and it's very interesting now to check how it's different in human and dogs. Thank you, Kenji, for joining.
Hi, Alan. So thank you very much for giving me an opportunity. And today I would like to talk about anti-IL-31 receptor antibody in human atopic dermatitis and prurigo nodularis. And unfortunately, compared to canine atopic dermatitis, human atopic dermatitis situation for the treatment targeting IL-31 is way behind. There are many peripheral mediators of atopic dermatitis as shown in this slide, such as nerve growth factor, histamine, TSLP, IL-13, 4, and 31. But we also know that in human, there are two types of inflammatory skin diseases. One is histamine-sensitive skin disease, such as urticaria and partially insect bite. But most of the inflammatory skin diseases are histamine resistant, such as atopic dermatitis, prurigo nodularis, and others. So as you can see, histamine-dependent itch is mainly mediated by H1 receptor, but histamine-independent itch, there are several candidates, PAR2, IL-4, 31, NK1R, and TRPV1, TRPA1. And in 2011, we studied the effect of cyclosporine on itch, and we discovered that cyclosporine relieves pruritus way before resolution of eczema, suggesting that cyclosporine's target, for example, T cells, play an important role for mediating itch. There are at least 3 types of helper T cell subset, Th1, Th2, and Th17. And as is already mentioned, type 2 inflammation is key pathogenesis for understanding the development of atopic dermatitis, and Th2 cells produce wide variety of cytokines, includes 4, 5, 13, 25, and 31. And very interestingly, an interesting study was performed in German group in 2004. IL-31, a cytokine produced by activated T cells, induced dermatitis in mice. This is a very epoch-making study. IL-31 intradermal injection itself could induce itch and subsequently eczematous skin lesions. And IL-31 is mainly produced by Th2 cells and also dendritic cells, macrophages, and endothelial cells. And the receptors is expressed on dorsal root ganglion, especially non-peptidic 3 population of DRGs. And IL-31 expression is normal in healthy and psoriasis patients, but elevated in AD and prurigo nodularis patients. And we also describe that effect of cyclosporine on pruritus, and also IL-31 levels decrease after cyclosporine treatment, suggesting that even in human, IL-31 may play an important role for the development of itching atopic dermatitis. So T cell produce IL-31 and act on IL-31 receptor on dorsal root ganglion and induce itch. And we also know that peripheral nerves distributed quite diffusely between keratinocyte, even under the steady state. But after the induction of inflammatory skin lesions, this distribution of peripheral nerve into the epidermis is more prominent, suggesting that the distribution of peripheral nerves in the epidermis may be the pathogenesis of maybe can be explained for alonesis or hyperenesis of atopic dermatitis. And one of the target of abnormal distribution of peripheral nerve is explained by IL-31, because IL-31 promotes growth of sensory nerves into the epidermis, by Martin Steinhoff and Bernhard Homi. So IL-31 is definitely important and key clinical target for pruritus treatment, as we reviewed recently. And there are several therapies under clinical trials targeting IL-31, include BMS 981164, lecanemab, and nemolizumab, and vixarelimab. And vixarelimab is oncocytin M receptor antibody. This is one of the heterodimer of IL-31 receptor. But today I'd like to explain the effect of nemolizumab anti-IL-31 receptor antibody, because this is already performed for phase 3 clinical trial. So this is a phase 2 clinical trial which we done with Thomas Ritziker and other colleagues, including Andreas Wallenberg and others. So after nemolizumab treatment, 0.5 milligram per kilogram every 4 weeks is the highest, shows the highest efficacy, and around 70% decrease of pruritus VAS was observed in 12 weeks after treatment. And also followed by improvement of dermatitis score measured by EASI, around 45% decrease by nemolizumab compared to placebo group. Another important point is nemolizumab improve quality of life, such as sleep parameters measured by actigraphy. So sleep onset latency, so time to sleep after going to bed, is shortened by 20 minutes. And also total sound sleep time has increased about 40 minutes, 30 to 40 minutes by this treatment, which suggests that improved pruritus can improve quality of life. And another study was demonstrated in phase 2 clinical trial, long-term treatment. This is an open label after 12 weeks period of placebo-controlled phase 2 clinical trial. And we followed until 64 weeks. And the percentage change of from baseline of pruritus VAS is achieved about 90% after 64 weeks by 0.5 milligram per kilogram treatment. And also EASI 50, EASI 75, and EASI 90 was sufficiently achieved by this treatment. And recently we published phase 3 clinical trial of nemolizumab with topical corticosteroid. And this also consistent with the previous data. Nemolizumab improved pruritus score in 16 weeks with topical corticosteroid, decreased by 43% of pruritus VAS score compared to placebo. And also there is another study by Sonia Sander group demonstrated that nemolizumab in moderate to severe prurigo nodularis. This is also a very difficult treatment, recurrent disease by conventional treatment. And this nemolizumab using 70 patients with prurigo nodularis and severe pruritus nemolizumab 0.5 milligram per kilogram subcutaneous injection at 0, 4, and 8 weeks improved 53% reduction of mean peak pruritus score compared to placebo group. This is one of the representative of the effect of nemolizumab compared to placebo group for controlling pruritus in prurigo nodularis. But on the other hand, antipruritic effect of nemolizumab in hemodialysis patient with uremic pruritus in phase 2 clinical trial was in vain. We didn't see any significant effect by nemolizumab 0.5 milligram per kilogram for uremic pruritus. And in mouse study, there's a new interesting study came out recently. Cytokine TGF-beta induces IL-31 from dermal dendritic cells to activate sensory neurons and stimulate wound itching. We experience itchy during the wounding, especially in the healing phase. And this is also somehow mediated by IL-31, IL-31 receptor signaling via dermal dendritic cell and dorsal root ganglion. So IL-31 play several roles in the development of pruritus, especially type 2 inflammatory conditions such as atopic dermatitis and prurigo nodularis. And in addition, wound healing itch is also mediated by IL-31, but uremic itch seems not to be mediated by IL-31, suggesting that IL-31 induce pruritus in a context-dependent manner. Lastly, I'd like to appreciate my lab members and also in Kyoto and in Singapore. Thank you very much for attention.
Yes, I would like to invite to the virtual podium Pascal Prelot again, who will present the veterinary experience with the first Janus kinase inhibitor that was approved in veterinary medicine for the treatment of atopic dermatitis, allergic dermatitis. Pascal, the floor is yours.
Yeah, I will speak about the oclacitinib, which was in fact a true revolution in veterinary dermatology. And first of all, a few words about the history of these molecules. It begins when Pfizer decided to split with the Pfizer Animal Health, which was then Zoetis. And when they decided to do that, they put in the pipeline a few drugs, including a JAK inhibitor, which was oclacitinib. And when this drug was used as supposed immunomodulating drugs in dogs with a pruritic dermatitis, the first results were highly spectacular. And then we discovered that the main role of the main cause of this spectacular effect was the inhibition of the effect of IL-31. And for example, here is some results of clinical studies. So you can see here in the black line the effect on pruritus of oclacitinib compared to cyclosporine, and the effect is quite fast, so much faster than cyclosporine when it is given twice a day, and this is important. And in these studies, it was given twice a day and then once a day, and you can see that when you give it once a day, since there is a short half-life, of course, there is a something which looks like a rebound effect compared to cyclosporine, which is slowly decreasing the score of pruritus. And trying to understand how it worked, it was discovered that the oclacitinib was mainly a JAK1 and also a JAK2 inhibitor. So maybe it acts like an inhibitor of the receptors for some cytokines, including IL-31 and other Th2 cytokines. But also it can act on IL-2 and IL-8. And since it is a JAK2 inhibitor partly, it can be also can induce some side effects by inhibiting some EP or I5, for example. But the fact that it works so fast was not so much explained by its direct effect on the receptors, even if it is credible. But there is some publication which prove very elegantly that this drug is not only a JAK inhibitor, it can inhibit directly TRPV1 by binding in the capsaicin pocket. So this drug can act in two ways to control pruritus, or at least. And as it is also an immunomodulating drug, it can also act on inflammation or cytokine, Th2 cytokine-induced pruritus. And it can also, with overdosage, provoke a decrease in the production of most of cytokines, but it is with overdosage. Or it can also deplete canine CD4 and CD8 in vitro, and this is why it is sometimes used as an immunosuppressive drugs, even if it is something which is quite not so much developed right now. So let's see how we use it in practice. Just a few examples to show how it changed the life of the vets, of general practitioners and dermatologists. Here is the typical case of a severe form of atopic dermatitis in a Staffy, which is an horrible, nice, unfashioned breed. This dog had a very pruritic lesions with a huge infection with the Staphylococci and malassezia. And this dog was normally would be treated with first antibiotics, antifungal drugs, etc. In this case, it was treated with oclacitinib and topical antiseptic shampoo. And in 2 weeks, thanks to the control of pruritus and maybe of part of the inflammation, this dog was fully cured and very comfortable. So this is the way it is often used, like really symptomatic treatment of pruritus for the short-term treatment. Another example is a terrible breed also here, which is the French bulldogs. This one was treated for years with steroids. And you see here, she developed side effects of steroid therapy with the alopecia and muscle atrophy. And this dog was still a little bit itchy with excoriation despite the long-term use of steroids. And this dog was one of the first I treated with oclacitinib, and we switched directly from steroids to oclacitinib. And in less than 2 days, the dog was not itchy anymore. And after 1 month, all the hair regrowth, because the dog didn't have any more steroids, and the dog was perfectly comfortable for years. So we could use it without any severe side effects for long term. But in these dogs, we saw it later, much later, 5 years later, and this dog developed complication of chronic otitis. And this is typical of the limit of the use of such drugs in our dogs. It is that, especially since otitis is a frequent complication of atopic dermatitis, we need steroids to treat it, and oclacitinib nor cyclosporine help treat otitis in these dogs. And the dog had a very severe otitis, and we had to remove the ear canal. And of course, after he was cured, because he didn't have any more ears, and he was still on oclacitinib treatment. So in practice, oclacitinib is first used as an antipruritic drug, not drug, but drug, in atopic dermatitis, of course, for the treatment of the flare and for long-term treatment, and also for flea bite hypersensitivity. And it is also used to control the pruritus in some parasitic disease, like here with a sarcoptic mange, which help match to have a good quality of life for these dogs in a few hours, because it acts very fast. So we use in practice oclacitinib for short-term treatment or control of pruritus, and also for the long-term even if we do not know what is the path of the control of IL-31 or immunosuppression with the use of this drug. But it's not a panacea. It's not efficient in all dogs at all. And we need topical steroids often for the long-term treatment to control some complication, like, for example, otitis. And also, we can observe sometimes rebound effect. And this is the results I showed you earlier with the nice effect of oclacitinib on pruritus. And if you can see, when you stop to give it twice a day and give it once a day, you observe this. You could say it is a rebound due to the fact that there is a short half-time for the efficacy of the oclacitinib. But if you look at the score, the lesion scores, you can see that it is still decreasing. So this could be a rebound effect. And this has been described in a mouse model, where when you give oclacitinib, you can see here you control pruritus, and when you stop giving oclacitinib, you have a true huge rebound with mice which are quite more itchy than the mice which had the control drug. What about the safety of the drug in the dog? We use it for almost 7 years, I think. If you look at the prescription of this drug, there is some contraindication. The first, that you must not give it to puppies. Do not give it if a history of neoplasia, deep bacterial infection, fungal infection, viral infection, pneumodicosis, nor primary vaccination. So this is the contraindication. But if you look at the side effects we observe in the routine, we observe the side effects of a drug which acts on cellular immune response, like pneumodicosis in the dog, papillomatous infection, and also histiocytic cell tumors. This has been studied in a few papers. Here is the comparison of cyclosporine and oclacitinib about the histiocytoma development, and you see that it was observed in 2.6% of dogs treated with oclacitinib versus almost 0.5% with the cyclosporine after 5 months of treatment. So it's more, but it's not so bad because it is a very benign tumor in the dog. And if you look at a recent paper which studied more than 6 months daily oclacitinib administration in more than 600 dogs, and compared to a control group with age and breed matching, there was not more mast cell tumors, there was not more squamous cell carcinoma development, and even if there was more lymphoma, it was 1.8% in the group treated with oclacitinib versus 0.3 in the other group. This difference was not significant. So, for instance, we consider that there is no pro-carcinogenic effect of oclacitinib, but I would say that it's very important to check these dogs very regularly, check the lymph nodes, and check any nodules which could appear in these dogs. In my practice, out of neoplasia, the two reasons why we had to stop the treatment with oclacitinib were the very spectacular weight gain without bulimia and aggression. And these aggressions are very spectacular, and they are really linked to oclacitinib because you stop, the dog has a normal behavior, you give it again the oclacitinib, the dog is biting all the family. So you have to stop that. And I didn't find any explanation of this side effect, which was described. It has been studied in the mice for tofacitinib and oclacitinib, and it seemed that only tofacitinib could induce such a behavior in some condition in the mice, but I'm almost sure that we have to work on the JAK-STAT pathway in the development of aggression in the dog, because maybe in some dogs there is something which is linked to that. So in conclusion, And then we can speak about the way we use all these drugs in the treatment of atopic dermatitis. Oclacitinib is used routinely now to treat acute flare of atopic dermatitis and the chronic itch or the chronic atopic dermatitis. In fact, it is very fast, very effective, maybe because it acts both on IL-31 receptors and TRPV1. Rebound effect can explain some rebound we observe in practice, but is quite less severe than what we observe with the steroids. And maybe in the future, we'll use these JAK inhibitors like immunomodulating drugs because we do not have so much drugs that we can use in the dog. Thank you.
Thank you so much, Pascal, for this nice review. We had some comments in the discussion about the papillomatosis and the HPV infection in dogs. So we need now to have this talk by Thierry on glucocorticoid, cyclosporin, oclacitinib, and anti-IL-31.
So I would like to take just a few minutes to introduce to the medical community and to those who are not aware some sort of a concept that my friend Fran Ivanovic and I published several years ago, how to position the different drugs that are available for treatment of atopic dermatitis. And what defined this concept was actually that the leading theme was that the breadth of target of the drug would dictate their timing of use. And let me clarify how we came up with this idea. If we have a dog with atopic dermatitis, as you can see here with the typical acute or chronic lesions, sometimes coexisting, it's very likely that we have in the dog, as in human, diagram of pathogenesis of the cutaneous inflammation that is very similar to this one. This is why, however powerful your targeted therapy will be, if you take out any of these cytokines, be it interleukin-31 or the interleukin-4 and L13, you will have to deal with the remaining inflammation in the skin for quite a long time. And this may explain the relatively low effect of any of the targeted therapies so far to treat the inflammation. If we look at what was presented for the nemolizumab or even for the lokivetmab, the effect on skin inflammation, the noticeable effect takes several weeks, as opposed to some of the drugs like glucocorticoid or even to some degree the oclacitinib, where the effect on inflammation is rapid. For oclacitinib, the effect on itch is also immediate. So if you have a dog with an active inflammation, we propose that first should be used broadly targeting drugs that have an active, a very rapid mode of action, like glucocorticoids, before we move to more targeted drugs. In contrast, when we have reached the stage of remission, we can expect that we have a skin that is still inflamed, but much less. And this is why the use of targeted therapy, for example, the lokivetmab, would be on board before the IL-31 is released or at the same time it is released. So we divide then the treatment of atopic dogs into two different phases. The reactive therapy is to take a dog that is like this, to lead him to this stage as rapidly and with fewest side effects as the one. And in that case, we propose to use starting with drugs with a broad target and a rapid action, which would be the oral and topical glucocorticoids. We are not advocating to use weeks of treatment, but to use enough medication or combination of glucocorticoids to lead as rapidly as you can to the inhibition of the active inflammation, followed by 2 to 3 days to consolidate that remission. And at that time, to switch to drugs with a narrower mode of action like oclacitinib, because the oclacitinib is a fantastic drug for the itch, but for the inflammation, it just blocks the signal of the cytokine to the cell. And as was shown by my colleague Wolfgang Bäumer using mice, during the first phase of oclacitinib in an active model of inflammation, the cytokines continue to accumulate in the skin early on, which is why when you decrease the drug from twice a day to once a day, because of the short half-life of oclacitinib, you have this rebound of pruritus. So we propose by using the glucocorticoid early on, we prevent the transcription of the cytokines, which would facilitate and amplify the effect of oclacitinib of inflammation. And your goal is a white patient, a white skin, non-inflamed, no visible inflammation, knowing that still microscopically there is inflammation remaining. And then we move to phase 2, proactive therapy. We have a dog that is this way, and we want to prevent the flare. And in that case, this is also the time to consider the allergen avoidance in case of a food-induced atopic dermatitis, or the use of immunotherapy to build up the tolerance to prevent the flare. And this is also where we think the lokivetmab has probably its best use, because you would put it on board before the IL-31 is released, so that it can inhibit interleukin 31 immediately after production. This is where also proactive topical glucocorticoid twice a week, every 3 days, for example, to prevent inflammation at the site of previous inflammation. And if you start having a flare, well, then you move in reverse with drugs with more a broader mode of action, looking at the oclacitinib again, and also cyclosporine. For me, cyclosporine is a wonderful drug with safety in dogs for the long term, because it tones down the inflammation and prevents the overall activation of a wide variety of cells. And obviously, once you reach that stage, you go back to your cycle with oral and topical glucocorticoids. We have had a tendency in veterinary medicine that veterinarians will switch from one drug to the next and eventually refer the patient when the drugs do not work. We contend that if there is a flare in case of a targeted therapy with lokivetmab or even with oclacitinib, that it is because there is the presence of mediators that are not blocked, either with the lokivetmab or the oclacitinib or the cyclosporine. And then in that case, you need just to hit the reset button with all glucocortics and possibly topical glucocorticoids. Enough to go back to the end of phase 1 and then start again with the drugs that worked very well in that patient. If the signs of a dog responded beautifully well to lokivetmab or to the oclacitinib, it's very likely that they will respond again. It is only the rare patient that will develop anti-drug antibody with lokivetmab. So if the lokivetmab worked very well, stopped working, reset with glucocorticoid, go back on lokivetmab. It's not a reason to stop this drug, specifically if you had months of remission. So we call this dynamic sequential therapy. It's the ultimate individualized medicine, but we have several drugs with unique characteristics, and not all will be working for the patient all the time, and they will not be working for every patient. So this is time to understand and better appreciate how this drug works, so that we can use them in a sequential way for the optimal benefit.
Thank you. Very, very, very interesting. I think something to think about in human dermatology and atopic dermatitis field. So I was premature to introduce Martin. He's around, and Martin is a very well-known specialist of pruritus, applied to several disorders, especially atopic dermatitis. And I think all the presentations we had previously generate several questions, and I think that the talk of Martin, which closes this part, will address some of them. Thank you, Martin, for joining.
Thank you very much, Alan. It's a great pleasure to be with you all for this wonderful meeting. So I will close now and focus on itch and what we know in atopic dermatitis in humans with respect to biologics and JAK inhibitors. But first, before we can answer that, let me start with the clinic, because as we know, if we think about itching, atopic dermatitis is very heterogeneous, and we even don't know whether the itch mediators are the same if a patient wakes up in the morning because of house dust mite allergies with an urticarial eczematous reaction as compared to the more lichenified lesions. And with not a lot of skin barrier dysfunction, or this elderly gentleman who has a severe skin barrier dysfunction and a late onset with a normal IgE. Similarly, we have to assume that in atopic dermatitis also there are central mechanisms of itching, similar what we know from herpes zoster, for example, or prurigo forms, where in atopic dermatitis induced prurigo, there also are central mechanisms which change the plasticity in the spinal cord and the brain, as we know also from animal studies and from pain. So we also assume that also in itching, in chronic itching, there is also a change in the plasticity of the central nervous system, which also explains why we sometimes need medications such as opioid antagonist or SSRIs or gabapentin or pregabalin. So I would differentiate, if we think about itching, on first starting with the anatomy, because there are differences how we can also approach itching. So first of all, we have the cutaneous epidermal and dermal nerves, which can be activated, as Kenji has shown, by many mediators, endogenous and exogenous, as you also see, for example, fleas from the environment. In the canine atopic dermatitis, many receptors are plenished at the nerve endings, which then transfer the signal to the brain, resulting in itching and scratching. However, in addition, probably also have some forms of microinflammation, as we know in atopic dermatitis, as compared to psoriasis, also non-lesional skin, that there are also increase of inflammatory mediators, probably also itch mediators. And that may also explain why we probably also see that what we think about the itch that flares in atopic dermatitis, where we have microinflammation, already some itching, but clinically we don't observe the full clinical picture of an eczema yet. Then secondly, we also have the dorsal root ganglia, which are the factory for the proteins which are generating the mediators and the receptors which plenish the peripheral nerve endings, but also the nerve endings here in the dorsal horn of the spinal cord, which then transmit the itch signal, what we define as central itching. Furthermore, recently we have learned that there are many itch mediators, and also interneurons and astrocytes and glial cells can change the plasticity of the projection neurons in order also to facilitate chronic itching, such what we also observe, for example, in zoster, and what we think is also the case in chronic itching. So these are different mediators, different receptors, and different targets for treatment. So if we think more on the cellular level, what we know, we have already heard about histamine, atopic dermatitis, more histamine-independent itch, as we have shown 20 years ago, that proteases, toll-like receptors, many cytokines, neuropeptides, MAS-related GPCR, and several ion channels are involved in the transmission of itching in the peripheral nerve endings. Also, we have learned in recent years that there are several signal transduction pathways which also get activated, not only in addition to electrical firing, and also fine-tune and modulate the neuropeptides and the receptors which are communicating with the central nervous system. And this is, for example, BNP, but also opioids. And as we see here, also in the central nervous system, there are several mediators which have been identified, which are involved in chemical or in mechanical form of itching. In addition to that, the neuropathic itch is also important, as I have shown at the beginning, because what we have also identified in recent years in many groups, mainly in mouse studies, is that there are dorsal root ganglia, these NP1, NP2, and NP3 neurons, the NP3 neurons, which are also harvesting the IL-31 positive neurons. And there is electrical firing on the one hand, which induces the projection neurons and it leads to itching. However, also there are inhibitory neurons, and these inhibitory neurons can also suppress itching. And this is relevant because this is mainly what we are doing when we are scratching. Then we are releasing substances such as GABA or glycine, which suppress the itch neurons. And this also has a therapeutic effect because then I can also utilize maybe some of these mediators as agonists in the future to suppress different forms of itching. We have already heard, and I don't want to repeat this here, that many cytokines have been targeted in recent years in dogs, but also in humans, which we all know. And let's have a look at what they are doing with respect to itching. So let's focus on the itch mediators in atopic dermatitis: IL-4, 13, IL-31, oncostatin M, TSLP, and IL-1 alpha. So they all activate certain receptors, leading also to the induction of itching, because some of them are also expressed on sensory nerve ending. And it's not only an electrical firing which they can induce, but also sensitization of the nerves, which then can be easier also activated by other itch mediators in the inflammatory soup. In addition, JAK inhibitors can also suppress the cytokine-induced pruritus. So let's have a look at the different medications, what we know in humans, and we have heard a lot from Lisa Beck already in dupilumab, so I only want to concentrate here with respect to the reduction of itching. And the early studies already phase 2 and then phase 3, and also the post-hoc data clearly show that also dupilumab has significant effect as compared to placebo, which already starts at day 2 with respect to the reduction of itching. And dupilumab, as said, works here at the IL-4 receptor alpha unit, therefore blocking IL-4 and IL-13 induced signaling, which are also both itch mediators. If you look at the daily peak pruritus, you can clearly see here the differences to placebo. So a significant itch mediator as the first demonstration induced by cytokine. The second is lebrikizumab, so an anti-IL-13 antibody, which also has been shown in clinical trials to improve itching and NRS 11, at least 4 points already at day 2 in around 15% of the patient. So also an effective itch mediator from early on. And what you can already see is that and see in the next slides is that there are differences in the clinical trials, what was measured with respect to itching. Some use the VAS score, some use the NRS 11 score, some use the peak pruritus, and therefore it's mainly a little bit comparing apples with oranges if we think about comparing side by side these medication with respect to efficacy on itching. The tralokinumab, which is now approved in Europe, also has shown that it is effective in the worst daily itch score, also at an early time point. And here you can see the mean NRS score, also significant inhibition as compared to pruritus over 16 weeks. How about IL-31, nemolizumab? Kenji Kawashima already has shown, just again to show here the focus on itching and prurigo. The nemolizumab rapidly decreased the pruritus in atopic dermatitis as well as in prurigo. And this effect is on the one hand, as already has been shown also by our colleagues and hypothesized, and I agree with it. It's probably a direct effect and indirect effect, and even maybe also in addition a central effect, because we have shown that IL-31 receptor is also expressed in the dorsal horn of the spinal cord, and since medication can also penetrate in via the blood system into the spinal cord, there may be also some inhibitory effects in addition in the central nervous system. Here, the mean NRS 11 itch scores, which shows clearly here the reduction in different dosages, as already has been published and shown by Kenji Kawashima. An interesting cytokine which has not been discussed so far with respect to itching, and this is very novel because it's a phase 2A clinical trial which has just been started, and here in September 2021, but the preliminary data have shown that there is also a 68% improvement in NRS 11 score with bermekimab, and therefore one could also hypothesize that it may also be an important itch suppressor, maybe also in other pruritic diseases. We will have to see in the future, and also whether it is a direct or indirect effect. So why are there differences in atopic dermatitis? And as you already have also said, is why do some patients respond better to certain therapies and others? So this is what we have published in 2014, the qPCR study. If you compare normal skin, psoriasis, atopic dermatitis, pruritus cinemateria, prurigo nodularis, and look at IL-31 receptor, and this one column is one patient, what you clearly can see here that there are differences with even in atopic dermatitis with respect to IL-31 and IL-31 receptor levels, suggesting that atopic dermatitis is a heterogeneous disease, and in the inflammatory soup of a lesion, there may be some patients who have high levels of IL-31, some may have lower levels of IL-31, but may have higher levels of IL-13. And that suggests to me that there's probably, we have to have targeted therapies for the patient depending on the level, and some may benefit more from IL-4, IL-13 or IL-31 treatment. Let's go to the JAK inhibitors, approved here baricitinib, in clinical trials abrocitinib, upadacitinib, and let's have a look what they are doing with respect to itching. Baricitinib has also been shown that it is in the NRS 11 score effective for the treatment. Abrocitinib also significant different to placebo as well as upadacitinib from early on. And also it is my clinical experience using all baricitinib and upadacitinib that there is definitely a fast onset of an antipruritic effect in these patients also who are not responsive to dupilumab. So accordingly, there was a head-to-head study, UPA versus dupilumab, and just to show here the itch, as you can see, almost 20% different in the percentage change of worse pruritus and improvement of pruritus in favor of UPA as compared to dupilumab. How about topical JAK inhibitors? Here, delgocitinib, which is approved in Japan, and I also have a patient here used it in some patients, also successfully for the reduction of itching, and it is really an interesting that also topical medications can be used at least in human atopic dermatitis, also for the reduction of itching. So that shows that there are probably many possibilities in the future, and it's a bright future also to suppress itching and in our patients. However, there are several open questions with respect to efficacy, head-to-head studies, side effect profiles, safety between biologics and JAK inhibitors in atopic dermatitis. And this is very exciting to study in the future together. Thank you.
Thank you very much, Martin. I've changed my background for the discussion. So I think now I see Peter, and based on our previous discussion, he will lead, I think, with Thierry and Pascal, the discussion with the panelists, which are already on the screen. And we have also other participants on Zoom, and also some delayed, I think it's a few seconds behind on YouTube. So everybody can send questions. We have already some questions. And so I ask now Peter to lead the discussion. Please, Peter.
Thank you, Anna, and thank you to everyone. I think we had highly interesting talks, and it's really very fruitful to exchange. I'm impressed by what our colleagues from Canine Atopic Dermatitis have already clear strategies how to approach the treatment. We had a really nice overview about many substances. Just in the beginning of the discussion, I would like to hand over a few words to Claude Favreau, because he has to leave earlier, because we have heard now a lot of using biologics. We have heard about using small molecules, JAK inhibitors, but I know that you colleagues from veterinary AD have also approaches to vaccinate against cytokines. And I think Claude Favreau has some experience with that. And I would like to hand over to him to give a few words on that. We can discuss it later, because of course that would be a very interesting approach also for canine, but also for human AD. Instead of blocking the cytokine, vaccinate against them. So Claude, I think you are also online.
Yes, I am.
Okay, then I would give you the word, because you have some experience with, I think, anti-IL-5, anti-31 vaccination. Please give some impressions.
Okay. Regarding anti-IL-31 vaccination, I have made a study with my model of atopic dog a few years ago. The vaccine was produced by the team by Martin Bachmann, probably known by most of you. The model that we are using is a little bit different from the model presented by Thierry a few minutes ago, but still we are stimulating the dog, we are sensitizing the dogs without the smite, and afterwards we are challenging this dog, usually every 6 or 7 weeks. And in this context, we have used a vaccination produced by Martin Bachmann's teams, which was VLP-based vaccination against IL-31. It was a relatively small study, because we had only 12 dogs, 6 for the control and 6 for the main group, the treated group. And we have observed a reduction of both the pruritus and the clinical lesions in the treated group, in the vaccinated group, in 5 out of 6 dogs, which was very, very impressive for me, because the reduction of pruritus and lesion was very, very dramatic and very quick. I think this product is not currently marketed, or even in the development stage. Is more question that the company has bought the rights for this vaccine, and we do not know exactly if they plan to develop or not this vaccination, but this first result very, very impressive. But still, One of the most interesting for me was also that one dog did not respond at all to the vaccination, suggesting that a little bit like Thierry suggesting a few minutes ago, EL31 is probably not important for all dogs with atopic dermatitis or an atopic dermatitis-like syndrome. You have also mentioned EL5. I am currently testing a vaccination with EL5, but for cats, not for dogs. And I do not think that I'm allowed to give any information because the study is still ongoing and I do not know exactly the results. EL5 was also used in equine. So basically, yes, we have quite a lot of different approaches using vaccination. What I would like to say also is that in dogs, we are using a lot of immunotherapy because that's for me still the only way to really treat the disease, the allergic disease, and we have several approaches and we have made some very beautiful progress. And when we are speaking with human colleagues, sometimes we are surprised to see that dogs and cats are responding better to desensitization than human beings. For example, we are using in Zurich desensitization using DRF2, the second allergen of house dust mite. And this desensitization is working in about 75% of the dogs and in almost 80% of the cats which are sensitized to these allergens. I don't know, Peter, if it was what you expected from me.
Yeah, no, that's fine. Can you comment on possible side effects? I was very surprised, for example, that some dogs get aggressive with some therapies. Do you observe something like that or other side effects if you somehow long-term inhibit cytokine?
No, the studies that I have done were relatively short and it's impossible to observe this type of side effects. And I think the aggressivity or the aggression that have been mentioned by for oclacitinib, that's something that we are seeing very, very rarely. I'm surprised that that Pascal mentioned that. I think I have only one case in my experience. But it was not really associated. It's a little bit different. It's not a vaccination. It was oclacitinib in this case. I'm not aware of any aggression associated, for example, with anti-EL31 antibodies or vaccination.
Mm-hmm. Anyone from the audience has questions regarding vaccination against cytokines?
This is Lisa Beck. I'm just going to ask, would you be worried vaccinating with IL-5 that in an animal that's prone to parasite infections, you would permanently put them at risk?
That's a very good question. Right now, we are testing a vaccination for EL5 only in indoor cats. And that's exactly for this reason, because we do not want to have this type of side effects. That's a question that we will have to answer before to go to the market. That's sure. But right now, the cats that we have involved in the study were only indoor cats, meaning that they have very few or not at all contacts with parasites.
I have a general question to the audience, if I may ask. We have Malassezia and Staph aureus and herpes simplex as the most relevant infectious agents for the humans. Would there be similar pattern in the dogs, or is it that you have other pathogens that your focus lies on?
If I can answer the question as well, for us in atopic dermatitis patient, most important agents are Staphylococci, not aureus, but Pseudointermedius, and also Malassezia pachydermatis, meaning that it's exactly the same.
In the chat, there's a a discussion about oral papillomatosis, I think, which you see in dogs. Is this a common problem in AD?
No, it's not. It's not common. It's common in puppies, which are immunosuppressed, and it is safe-cured most of the time. So in dogs with immunosuppressive drugs, you can have that too, but it's easy to control.
Yes, I would like to confirm that in many of the drugs that the immunosuppressive drugs that we give do not take into account that the patient may have a borderline functional immune system. And even in an immunocompetent patient, a short course of a JAK inhibitor or cyclosporine, a course of a JAK inhibitor or cyclosporine can lower the T-cell response. And then we see papillomavirus infections, Demodex infestations, or the appearance of benign tumors, like Pascal mentioned, the histiocytomas that normally regress with cytotoxic T cells. So it's not a side effect of the drug; it's just a pharmacodynamic effect of the drugs. But the pox virus infection, the herpes virus infection that you see in humans, as far as we know, are not seen in the dog. In the cat, herpes could be a problem, but we don't have so far any feedback about worsening of herpes after using a cyclosporine or JAK inhibitor in the cat. But in the dog, we don't see these.
Okay. One thing we were briefly discussing yesterday is that in human AD, we quite separate between AD in childhood, in young infants, and in adolescents or adults, which are somehow, there are also difference. I think in the dogs, you don't, you treat all the same, or are there also difference, or is it more lifelong treatment for every dog that you do?
Claude?
I don't think that there is a huge difference because of the age. First, because the dogs are not so long living, and also probably because we are seeing the dog a little bit late, probably later than the human beings. I was a little bit surprised, or not surprised, but I remarked that Pascal mentioned that there is no atopic march in dogs. I'm not so convinced, because we have made a study a few years ago where we have followed puppies of one specific breed, the West Island White Terrier, during 3 years to detect the onset of atopic dermatitis. And we have remarked that the great majority of the dogs that were atopic at the age of 3 years had the first symptoms, the first signs during the 6 first months of life, meaning that there is a progression of the disease, but usually these signs were very, very mild. That's the point. But regarding the type of treatment, I think in veterinary medicine, that's more the breed than the age that is very important, because we know that some breeds are responding better to some treatment than the others, and not specifically the age.
Mm-hmm. Pascal, would you like to comment on that, or?
No, I do agree. Sometimes there's so much difference between breeds that we could consider that it's not always the same disease depending on the breeds.
Okay. Mm-hmm. Do you see comorbidities in your dogs? Like in humans, we see, for example, asthma, food allergy, or others. Do you see that also in dogs?
Food allergy is for us sometimes the cause of atopic dermatitis, so it's not really a comorbidity, but we observe that some dogs as the food as the main triggering factor for atopic dermatitis. For the others, I'm not so convinced. Probably the exception is in cats, where we have sometimes the impression that behavioral problems and atopic dermatitis are are playing together, I would say, to create a more severe disease. In some cats, sometimes it's very difficult to determine if the patient has atopic dermatitis or the psychogenic dermatitis, and probably it's both together. So it's for me the most important comorbidity that we are observing in animals.
I would like to comment on that, something that caught my attention about behavior. And I would like to ask our veterinary colleagues about stress or the lifestyle of the dog nowadays, that sometimes the owner leaves the dog inside the house and the dog's not exercising as much. And do you think all those factors can affect the increase of atopic dermatitis in animals in general?
It can worsen. Sorry, you wanted to answer, Claude?
No, it's okay. It's okay.
Yeah, it's not the cause of a flare, but the dog are itching more. So it is, and once again, it is really breed dependent. For example, in French bulldogs, which are very active, very anxious dogs, sometimes you need to use clomipramine or fluoxetine, and it helps match to treat both the behavior and the atopic dermatitis too. But in fact, we don't have so much good studies on the link between both.
Do you consider the owners as the causes? Also?
Like the mother for human, the owners are the main cause. Yeah.
I have the example of I have treated a few years ago. It was a very strong allergic dog, and for this reason, the owner did not want to keep the dog. So we have to find another house, another family, and afterwards the disease was less severe, really less severe when the dog was in another family, meaning that probably some psychological factors were playing a role in this dog at the least. But it's anecdotal, it's not really proven, but I'm pretty sure that these factors are playing a role in dogs as well.
Thank you.
Mm-hmm. In the chat, we have quite some questions referring to cytokine or cytokine receptors in the central nervous system, and questions are whether we should not address this cytokines there instead or in the skin or parallel. Maybe Martin or someone else from you can comment on that.
Yes, thank you. So evidence indicates that the main effect is in the peripheral nervous system, also from the kinetic. However, we cannot exclude that there may be some effects also in the central nervous system, because we know that the receptor is expressed in the dorsal horn of the spinal cord, and also we know that there are other cytokines and chemokines also then upregulated and dysregulated in the central nervous system, in such as IL-33, some chemokines, and we know from pain studies and with using antibodies that also they are effective in treating neuropathic pain. But we have much poorer evidence with respect to itching, but along that line, one can assume it.
Mm-hmm. Thank you. Then two things. One is the nutrition, which seems to play quite an important role in canine atopic dermatitis. You really work with that. You may know in humans there are some approaches with probiotics in infants, in children, but not really in adults, or really not really something convincing. Maybe you can, from the vet side, you can comment on that. What approaches you use? I don't know who want to comment on that.
Maybe I can comment, because I have made the study mentioned by Pascal at the beginning of this afternoon. What was done with the dogs, that was the company Royal Canin has developed a specific food, not only with essential fatty acid, but with a lot of different components, antioxidants, and also a lot of different ingredients. And what we have observed is that after 2 months, we have a clear decrease, not only in the drug use, but also in the Pareto score and in the lesional score, meaning that it's probably possible in dogs at the least to improve atopic dermatitis only with some food components. Here you are mentioning, Peter, prebiotics. It's a different approach because it's more to modify the microbiome probably of the animals, and I know that some teams are working on this field in veterinary dermatology as well, but as far as I know, we do not have a lot of convincing results right now. There is 2 or 3 different studies where prebiotics or probiotics were used, and the results are not very, very convincing right now.
Ola, you have quite some experience.
Peter, there is a message of Laurent indicating that we have questions coming maybe directly on the from Gail, Daniel, and Dr. Smadens.
Okay.
So we can take it maybe if it is possible.
Of course. So, I don't know, Daniel, would you like to start?
Yes. Hi, everybody. I was just wondering if once you get a response in cats or dogs particularly treated with anti-JAK or dupilumab, do you get sometimes this psoriasiform expression more visible? Because we see that in not completely responders, particularly in Asian patients. I'm working in pediatric dermatology, so amongst my patient with AD of Asian origin, sometimes they respond quite well with regards to their atopic dermatitis, but there's like an hyperkeratotic inflammatory eruption on the extensor surfaces, much more psoriasiform phenotype. I was wondering if you observed that in veterinary medicine.
So maybe I can give my viewpoint on this. First of all, the dogs don't have the typical psoriasiform response as you might see in humans. We have some breeds in which you have epidermal hyperplasia and hyperkeratosis as a prominent form of the prominent manifestation of atopic dermatitis, and I'm thinking of the West Highland White Terrier as a beautiful example, or the German Shepherd with chronic atopic dermatitis. In these patients specifically, when we use broadly deactivating drugs like cyclosporine in the long term, we have resolution of these hyperkeratotic and lichenified skin lesions. So we don't see, I've not observed what you describe, a worsening of the lesions that become more hyperkeratotic. Having said that, there is a very unique manifestation of dermatosis in the dog that we call lichenoid psoriasiform because of the histopathology, which can be actually a side effect of the cyclosporine administration. It seems to be an unusual response to staphylococcal infection. Antibiotic therapy usually resolves the issue and reduction in cyclosporine, but that's an oddity that does not appear to be seen with the JAK inhibitors. I don't know if Pascal or Chie or Claude can comment, or if they have seen that the lichenoid psoriasiform with JAK inhibitors.
No, I do agree with you. I don't see though.
Is anti-drug antibodies a topic in veterinary derm?
Like anti-drug antibody, yes, it's been something that has come up with the lokivetmab, which is, if I recall, something like 97% caninized. There is still the small antigen binding region that is of mouse origin. The anti-drug antibody have been observed, but in an extremely small percentage of patients. It is easy to blame the lack of response. Let's say a dog whose signs responded very well to lokivetmab, suddenly the signs flare. It's easy to blame, oh, this dog has anti-cytokine antibodies, but it's most likely because of the emergence of other cytokines or mediators that are relevant. The dogs in which we suspect the anti-drug antibody are in which, let's say in the US, the lokivetmab at 2 milligrams per kilo leads to an improvement in 6 weeks initially, and after a while it becomes 4 weeks, 3 weeks, 2 weeks, and then it stops working. That's the type of patient where we suspect that we have anti-drug antibody development, but it's this would be a very rare patient. I don't know, is it an issue for you with dupilumab, or because they are fully human or humanized antibodies?
Dupilumab, not so much. It's more with the older anti-TNF antibodies. But most things that we have in AD, they are pretty safe regarding that. Thank you.
Okay, there's quite a lot of going in the chat, and I think Gail Todd would also like to ask something. I think you can express your live.
Yeah, this is Lisa Beck. I did put in the chat because Pascal said at the beginning that you don't see an atopic march in your canine AD, and yet you do think they have food allergy or that food avoidance can sometimes help them. So at least they have that one concomitant comorbid atopic condition. I clearly had a dog that had horrible allergic rhinitis and AD, but how often do you get sinonasal features, so upper respiratory versus lower respiratory features in your canine AD patients?
I can answer. Yeah, for me, there is no link. It's really not described. You can have dogs with a recurrent chronic sinusitis, but it's not associated to atopic dermatitis. And as far as I know, there's not so much allergic exploration of these dogs nor cats. The other point is for conjunctivitis, which is often associated to atopic dermatitis, but which also can exist without atopic dermatitis.
But we don't see typically the progression of atopic dermatitis to asthma for a surprising reason. Bronchial asthma or chronic bronchitis in atopic patients are related to allergies is, I would say, fairly exceptional. And I don't understand the rationale why we have this difference.
I think next question, I would invite Gail if she's online.
Hello.
Hello, please go on.
Well, I want you to let me know if you have seen some adverse reactions following the use of lokivetmab in dogs with atopic dermatitis that can have a flare or pyoderma developed after the second or third injection of lokivetmab in dogs that were absolutely under control. Thank you.
The question comes not from Gail, but for Dr. Manigault. And I think she is a vet doctor.
Yeah.
Yes.
Yeah, I would say we observe whatever the treatment is in dogs which are perfectly controlled, some huge flare of pyoderma sometimes, whether it is with lokivetmab, clocitinib, or cyclosporine. It can happen. It can be linked to flea, to maceration, to whatever. For me, there is no link with the treatment.
And for me, I would look at the fact that lokivetmab only blocks one cytokine that may not be terribly important for inflammation itself, and that the use of the lokivetmab alone might have kept the inflammation in the skin that leads to the dysbiosis and pyoderma. So I would not call that a side effect, but an insufficient control. of the inflammation.
Thank you. I forgot to say that this effect was observed 24 or 48 hours after the injection of the Lokivet-mab. Thank you. That's the question I was asking.
Okay.
Thank you.
Then there's Dr. Madden who would like to ask something.
If not, I would like to ask a question to our vet colleagues. When we read the literature, I think concerning animal models of human AD, I think most are concerning mice, and there are different models of mice. NG and J is maybe the most common, especially in Japan, but there are many others. And what do you think yourself, from your perspective of vets, concerning the question of animal models for human atopic dermatitis?
This one is for Thierry.
Well, if we look at the traditional models for human atopic dermatitis have been various types of mice, and they reproduce some or many of the changes that you see in humans. I am biased in that I think that the dog is the only species with a natural model of atopic dermatitis, but having an experimental canine model of AD, and I know Claude thinks will support me in that. It's very expensive. It's very difficult. So I see the use of animal models in a different way, that perhaps we could look at first using rodent models to do the preclinical, and then looking at if the drugs of interest have an appropriate safety profile in the dog, using patients in the clinic to test the efficacy in a more natural way. The house dust mite canine model is beautiful, but there are very, very few colonies available, and it's quite difficult to test in the long term.
I think now Dr. Madden is ready for his question.
Yes, sorry, I had my micro off. And actually, Professor Steinhoff already partially answered my question regarding the relevance of central nervous system importance regarding to itching compared to the peripheral peripheral nervous system. And actually, I understand that the central nervous system is less involved than the peripheral one. I have a question which is more general regarding the developments either in veterinary medicine or human medicine for more specific either small inhibitors or antibodies that would have less off-target pharmacological effects. Are you aware about any developments for more specific drugs?
Who would like to?
There may be known. Okay, that's fine. There may be known other developments so far. Okay.
Well, there are obviously because Apoquel is such a wonderful drug. There are multiple drugs and in development. Some are obviously likely to be other JAK inhibitors, but at this time we have not. I know that there are drugs in development, but we have not seen any other. There have been drugs that have been tested in animal models that have not been very successful. And for example, in the JE years ago, CCR4 inhibitor, which as the CCL17 TARC receptor would have been a logical target, and it did not meet. It was not very effective. we tested some H4 receptors, antagonists topically and orally in our dog model of atopic dermatitis, and this was also a very specific, inhibitor, but we didn't see any effect. So this is why I'm biased in the semi-broad or broad antagonist to treat active disease, because if you try to even prevent relapses with a single inhibitor, the challenge is that the bar is very high, and it's very difficult to achieve that.
Okay, thank you.
It seems that Jude Reed would like to ask something. I don't know if you are also online, that you can ask your question by the microphone.
Can you hear me?
Yes, we can hear you, Jude.
Okay, hi, yeah. I'm afraid I'm not as scientific as most people on this call. I'm a pediatrician that looks after a lot of children and babies with eczema and allergy. And by I also have a guide dog that we look after who, interestingly, has had atopic dermatitis. So I've been very aware of the links and the relationship, and it was been very interesting watching the different approach from a veterinary perspective of the treatment of our guide dog compared to how I treat children. And very much, I think Apoquel was put in very early, and I find we struggle very much with itch in children to manage their itch with antihistamines, which, as you say, in atopic dermatitis, antihistamines don't really work and are not really helpful. And in early onset eczema, we very much look early on in severe early onset eczema in children about food allergies. And they did do an exclusion diet for the guide dog, but I wasn't clear on what foods we're actually looking for in guide dogs. Whereas in babies, it's very much egg is the most common allergen in atopic dermatitis, followed by cow's milk. What are we looking for in dogs?
Yeah, do you hear me? Yeah.
Yeah, I can hear you. Sorry.
Yeah, for the dogs, it's almost all the proteins of meat and milk and etc., which are the main food allergens. And fortunately, we have highly hydrolyzed dry food. So we use this type of food to do eviction diet, or even to give that to the atopic dogs all lifelong.
Right, okay. And sort of role, I was just thinking from a microbiome point of view and thinking of things that you can use with dogs, sort of things because topical moisturizers, as you say, aren't readily used or easily to apply to dogs, which is our mainstay of treatment in infants and children, in addition to obviously your topical steroids. So is there a role at all for any emollient therapy in dogs, or sort of coconut oil or anything like that? What's the...
Put it oil on all the body is not so wonderful, but there's refrigerant topical products as foam, as a spot on, and yeah, we don't use too much ointment, but we like to use refrigerant topical emollients.
On that line, since probably around 2000, most of the major pet food companies have developed diets for sensitive skin or allergic skin that are highly enriched in omega-6 fatty acids and omega-3 as well, which have been shown to also help restoring the skin lipids. So instead of targeting through the emollients, we target through the gut. And a couple of months later, it's been shown that you have an increase in ceramide content, you have an increase in fatty acid in the skin, and you have a reduction in transepidermal water loss and a normalization of the lipid lamellae on electron microscopy. So this is the same strategy, but adapted to the fact that our patients are covered with hair.
That's really interesting. So there may be some benefit. I don't know if anybody's looked in humans about looking at more. Obviously, we use hydrolyzed formulas if you've got cow's milk or egg allergy, but is there a role for looking at diet in toddlers and babies who often are quite restricted in their diet and picky at what we ingest, rather than using ceramides on the skin, which the NHS often doesn't support the more expensive emollients with the ceramides and the fatty acids in?
Can you give a short answer, because for time reasons we soon have to close the meeting. Or is there any short answer possible?
Possibly just an interesting statement.
Okay. Maybe there's one question from Alberto Martin, who is long waiting, and an interesting comment from Lisa Beck. And then I think we should conclude, because we could go for hours, but also that we keep our schedule. Alberto, are you online?
Yes, thank you, Peter. I'm Alberto Martin Cordero from Mexico. I have a question. I have witnessed that some of the giant dogs, we have been using less dose of lokibetamab, as it's an expensive drug, especially for dogs over 40 kilograms. I have several patients that are over 50, 60 kilograms, and I have been using 140 milligram vial, and it seems to work fine. And it's different from other weights. If, for example, I use a 10 milligram vial in a 20 kilogram dog, probably won't work the same, and I have seen that. Have anybody else has the same experience, that you can use a lower dose in giant dogs with a good response?
I don't have so much experience of giant dogs, because in my experience, they are not so much atopic, in fact. But what I observe, it's almost the same. It is a huge difference of duration of the effect of lokibetamab depending on the dogs. In some dogs, you can inject it, it can be active only 2 weeks, and in others, it can be active 3 months for the same dosage. So I think it's more on the duration of the effect than the dosage, which is important.
Mm-hmm.
Thank you.
A question from Gail Todd on resolvins. How do biologics interact with resolvins to modulate, improve resolution of the inflammation in AD? Anyone is very familiar with these kind of substances?
Well, on the veterinary side, we don't have any data on resolvins and atopic dermatitis, so no comments.
Okay, thank you. Then Lisa Beck, I don't know if you want to give your comment in person. You wrote a very interesting observation about veterinarians who come to see you for urticaria and eczema. You're still online?
Yes, Peter, I was just really intrigued and laughed quite a bit with my vet patients who are coming in often for dupilumab, or in one case for Xolair for her chronic urticaria. They come in showing me that their canine patients are allergic to human dander. And so I just wondered, is that a common thing? Because I certainly have a lot of my AD patients who are highly sensitized to dogs, and when they go off to college, they get quite a bit better.
Well, the human dander have been included in skin tests in the 80s for no reason, but there is no known documentation of a very well described case of a dog with positive provocation to a human contact.
And the same for the cat also.
Yeah.
So they've ground up keratinocytes from human scales and injected them?
Yes, but obviously this is not a well characterized extract, and I don't know even if it's free of monotoxin or the like. But so far we have not had we have not had good demonstration of positivity to any of the known human allergens.
I mean, theoretically, this would be a much bigger load. Let's say if it's real, it'd be a much bigger load in a house that's congested with more humans, particularly if they had eczema or psoriasis, where there's a lot more dander being produced, right? Because the epithelium turnover is really high. I mean, you should know that I think there's sort of credible data that humans can be allergic to themselves. And so taking some of those, I think it's Home S1 was one of them. There was one called NAC. They actually isolated what proteins in keratinocyte lysates, were bound by IgE. It might be interesting to do that because I find it hard to believe they wouldn't be.
Yeah, so we have done that in the dog. We looked at the autoreactivity on epidermis, on epidermal keratinocytes, looking at stressed keratinocytes, stimulated them with TNF, stimulated them with allergens to see if we would have an autoreactivity. We also looked at this autoreactivity using sera from dogs that had high IgE level against dogs, and we could not characterize any bands on Western blot or by immunofluorescence. Same thing based on Peter's work on the Malassezia superoxide dismutase. We did the same thing, taking IgE from dogs that had serum from dogs that had IgE against Malassezia, looking at reactivity against standard keratinocytes, stimulated keratinocyte, stimulated in a different way to see if we could document the same type of Malassezia-induced autoreactivity, and so far nothing. So this was several years back, but so far there is no evidence, at least, of autoreactivity in the dogs. That doesn't mean it doesn't exist, but we didn't find it yet.
Very interesting observation. I think the mutual exchange is really highly interesting. For time reason, I think we should stop now. I can announce that everything will be in a few days available on a video. I would also like to thank, we have more than 150 attendees who followed up this session. And I would like to thank all the contributors, and maybe for the conclusion, I would like to hand over to Alain and you, Thierry and Pascal. It was really a pleasure to participate in this session, highly exciting. I could go on for hours exchanging. I think we should repeat this maybe in a while. It's really very rewarding. Maybe I give the word to you, Alain.
Well, thanks very much, Peter, for moderating this discussion session. And I want to also to thank very much our colleagues, especially Thierry and Pascal, who helped us to build this program, mixing the opinions and experience of vets and human doctors. I think it's probably important to consider that we should meet again, because there are progresses in both fields, and I suggest maybe to have another session maybe in 1 year from now, because we have the next physical meeting, also could be also physical and virtual meeting in Montreal, who is organized by Daniel Marcoux. So I want to thank also Laurent Elga, who managed the technical aspects and who has organized this live streaming with also YouTube restreaming. So we have quite a good live audience, and also the fact that this symposium will be available in replay, I think will also increase the impact. And my thanks also to all the colleagues from the veterinary medicine who joined ISAD on this occasion. So I let Thierry and Pascal finish the conclusive remarks.
Yes, thank you very much, Alain, and thank you to you and to the ISAD for inviting several of us. It's really a privilege to lecture and to participate to this webinar. For many years, we what you have done in the human field has been a source of tremendous inspiration for all of us. And what I see very unique at this stage is that the development of therapeutics is similar but somewhat different, which means that you get to test some drugs first, which gives some ideas to animal health companies to maybe develop the same or at least test the drugs. And at the same time, we are, thanks to the prescience of some of our colleagues, scientists at leading pharmaceutical companies, we have access earlier than you do because of the shorter development process to drugs that you don't have. So you can also look at, we can maybe once be a source of inspiration as we have years of experience and maybe fewer restrictions to use some of the drugs. We were discussing yesterday that you mentioned that dupilumab in France has to be injected in the hospital first. Well, here the lokivetmab is used by general practitioners all over the world now, in many countries. So, but anyway, I hope that we can continue these exchanges as every few years as we have new drugs, and we certainly we watch closely what you're publishing on the human side. And thank you for being such an inspiration. Pascal?
Yeah, wow, how can I add anything with your enthusiasm? I agree with you. It was really good. I'm very proud because I think there was more vets than humans. And this is classical because we are used to be interested in different species, and especially the two legs one. And I'm sure that we will have quite much more exchange, and it was just a small beginning, and there is a lot of the subject around the infection and around, we saw on the Psy area, etc. And I'm sure that in 1 year, Montreal is a good appointment for next exchange. And thank you, Alain, for this.
You are all welcome. We're counting on you.